Sir, shall we start, sir? Someshwar is not clearly visible, sir. Please. Sir, shall we start, sir? Someshwar is not clearly visible, sir. Please.
కొంచెం లైటింగ్ పెట్టుకుంటే సరిపోతుంది సార్.
Somewhere is echo, Lokesh. Can you check?
వీళ్ళెవరు మన ఈసీ మెంబర్స్ ఎవరు రాలేదు కదా నరేష్?
They may slowly join, sir. We'll.
Okay, no problem. Nice.
Good evening, everyone. Welcome back to the OSSAP web series of online teaching education program. We took some short break because of increasing numbers, and then we are back with academic sessions again. As the cases go on, I think our education should not stop. We will continue to do our online teaching schedules. On behalf of OSSAP, it's a great privilege for us to welcome Dr. Srinivasulu Metikala, MD from orthopedic surgeon. Got trained, is basically from Kadapa, and then got trained in multiple places in Andhra Pradesh and also in Telangana. He gave his services and then now settled in USA, and he specializes in foot and ankle services. So welcome, sir, Srinivasulu. Welcome to the webinar, and this is being hosted by Kadapa Orthopedic Society Association. So I welcome Jahangir Basha from KOSA to the group, and Achutrao Garu from Kurnool, and Dr. Atmaram Adishesh from Anantapur.
Hello.
So thank you for joining us, sir. And our most dynamic President Subramania Rao Garu for taking initiatives and continually keeping us on track. Whenever we go out of the track, he will bring us to the track and keep us on track to go ahead. So with this small introduction, I'll request President Dr. Subramania Rao sir to welcome the crowd and start the proceedings. Sir, please.
Yeah. Good evening, everybody. On behalf of KOSA, Kadapa District Orthopedic Surgeons Association, and OSSAP, Orthopedic Surgeons Society of Andhra Pradesh, I welcome Dr. M. Srinivasulu, renowned orthopedic surgeon. He was with us in Kadapa for some time and then now settled in Virginia, USA. I personally know him for the past 20-25 years. He's good at his academics. At the same time, I welcome all the other panelists, Dr. B. Someshwar Garu, Professor of Orthopedics, Santiram Medical College, Kurnool, and Dr. Achutrao, renowned orthopedic surgeon, Apple and Medcover Hospitals, Kurnool, Dr. Atmaram, Professor of Orthopedics, Anantapur Medical College, Anantapur, Dr. Ravi Shankar, presently working as Associate Professor in RIMS, Kadapa, and Dr. Jahangir on behalf of Kadapa District Orthopedic Surgeons Association. Welcome you all, sir, for this webinar. As Naresh shared, we have to continue this academics as the number of cases going on increasing, and then our professional work, regular orthopedic work comes down. So let us educate ourselves and refresh ourselves with our academic activity. Now I welcome Dr. Srinivasulu to continue his lecture.
So we have a small introduction of our Srinivasulu, sir. I think Jahangir, ready with the introduction?
Yes, sir. Sir, shall I just share the screen?
I can share the screen again. Lila, welcome.
Good evening, Lila.
Good evening, sir. Good evening.
Sir, am I visible, sir?
Yes, Jahangir.
Your screen is visible.
Screen is visible.
Sir. Thank you, sir. Good afternoon, KOSA and OSSAP. It's a great pleasure and honor to me to introduce about our Sir Srinivasulu sir. Dr. Srinivasulu sir is a native of Raichoti, Kadapa district, pursued MBBS from 1993 to 1999 and MS Ortho from 2000 to 2003. Sir.
Jahangir, can you put it in the full slide mode?
Full screen mode. Full screen.
Right, show, yes.
Yeah. No, right.
Sorry.
Sir. He continued further orthopedic training in England until 2006 and obtained membership diplomas from the Royal College of Edinburgh in England. After returning to India, he engaged in academic practice at SVS Medical College, Mahabub Nagar, serving as assistant and associate professor in the Department of Orthopedic Surgery, in addition to private practice at Kadapa throughout. He joined in AVO Trauma in 2012 and pursued AVO Trauma Fellowship in 2015 at Wake Forest Baptist Medical Center in North Carolina, USA. Subsequently, he was selected as a national faculty for AVO Trauma courses in India and served for 3 consecutive years from 2015 through 2017. Because of his ambition for a career in US, he left India in 2018 and trained through fellowship in foot and ankle surgery and sports from 2018 through 2020. He possesses several publications and presentations to his credit at various platforms in India, UK and US. He continues to serve as a peer reviewer for several academic journals in orthopedic surgery. Recently, he got an invitation to join as assistant professor in the Department of Orthopedic Surgery at the Virginia Commonwealth University, Richmond, which he will begin on 1st September 2020. We take this opportunity to wish him all the very best. So these are the various fellowships Sir has done. He did fellowship in orthopedic sports medicine, ACGME, and fellowship in foot and ankle surgery, pediatric orthopedics, limb reconstruction, orthopedic trauma. And these are the various publications done by Sir. And honors and awards, he has many awards under him, the best lecture, and these are the few. And for us, KOSA, he is the founder of KOSA OSSAP WhatsApp group. And through this, we have done many CMEs and also sharing of knowledge, and has been very useful to us and to different doctors, orthopedic surgeons in Kadapa. Sir, thank you, sir. Sir, please continue, sir.
Thank you, Jahangir. Thank you, everyone. First of all, very good evening to each and everyone. Thank you for your kind introduction and your commitment to academics on Sunday. I know almost all the panelists in person. It's indeed a great feeling to get connected with you all. Thank you again. Please note that this short lecture is no way to replace your vast experience, but is my attempt to share my knowledge that I had obtained over the recent years. So let's begin. We routinely see various fractures. Some are simple and stay simple, whereas some look simple to begin with, but get complicated after a while. And not uncommonly, we see fairly complicated stuff as well. So in this galaxy of ankle fractures, we really need to decide which ones can be treated without surgery and which need surgery. If surgery, what type of surgery, and in what sequence. So before we discuss on that, let's step back a minute and look at some classifications. These are very descriptive. The first one is based on the injury mechanism, whereas the other two speak about the location of fibular fracture. Why not we summarize everything and discuss into just two categories, the stable and unstable varieties. We know that sorry about the noise. We know that stable fracture is that fracture which looks stable and remains stable until union with no surprises, such as this, which does not need a surgery or a cast or a boot. Just an ankle brace suffices and the patients can wait there as tolerated. Of course, we need to obtain follow-up x-rays for monitoring the displacement. How about this? We have a lateral malfracture, which is hardly seen, but becomes unstable with gross lateral translation of talus just in a week time, despite being protected in non-weight-bearing splint. This signifies deltoid ligament injury, which is unfortunately not seen in radiographs. Then how do we diagnose them? Well, three things would help: the history of rotational injury, the tenderness over deltoid ligament, and finally, stress test. So what is the stress test? It's a simple clinical test that can be performed in an outpatient setting under live fluoro with minimal discomfort to the patient. It comprises of three things: hold the foot in plantigrade position, the other hand to stabilize in slight internal rotation, and gentle external rotation force to the foot should open up the medial space if there is an injury to deltoid ligament complex with medial instability. Well, why external rotation in plantigrade position? Because the deltoid ligament is the primary stabilizer for anterolateral talar displacement, and we are just trying to recreate instability with a manual force in the same direction. Then why internal rotation? Is basically to obtain a mortise view which helps to visualize the medial clear space better. So let's look at few cases. It's an example of a 55-year-old gentleman fell off a broken sidewalk, sustaining a closed injury to right ankle. We can see that the radiographs demonstrate a relatively undisplaced lateral malleolus fracture at the level of ankle joint. So we have just learned that we need to give an external rotation stress, and this reveals a medial space with lateral translation of talus within the mortise, which is definitely different from injury films. So though it appears well aligned, it is a potentially unstable type of ankle fracture that requires surgery. So during surgery, the posterolateral plate application was performed using a 3.5 Recon LCP with anti-glide principle. Of course, we can also use a 1/3 tubular plate. How to achieve this anti-glide construct? A cortical screw, when placed through the plate hole, just proximal to the fracture, can adequately reduce the fracture and restore the length of fibula. The fibular length can also be ascertained by checking the distal tip of lateral mal aligning to the level of lateral process of talus. Once happy, complete fixation using cortical screws proximally and locking screws distally. Why locking screws here? Not so much that they create fixed ankle construct, but mainly because the screw heads sit flush with the rest of the plate to avoid peroneal tendon irritation. And for the same reason, we also make sure that the inferior extent of the plate does not encroach onto the last centimeter of lateral malleolus. So we have now achieved anatomical length of fibula with equal clear space throughout. Does that conclude surgery? The answer is no, because we need to repeat external rotation stress test intraoperatively under live fluoro to look for medial clear space. If it opens up with stress test, despite anatomical plating of fibula, it indicates a residual medial instability that requires additional surgery to explore medially and repair the torn deltoid ligament. However, in this case, there wasn't any opening, so medial side was left undisturbed. With the standard post-op management, the patient was able to walk by 2 months without any assistive devices. So far, we have discussed that anatomical fixation of fibula would automatically restore the fibular length. but we need to ensure medial stability by repeating the stress test intraoperatively. So let's take a look at a different case. We have a 58-year pleasant lady fell off a ladder in a construction field, sustaining a closed isolated injury to right ankle. One can see a lateral mal fracture with a clear widening of medial clear space. But the decision was made for non-op at an outside facility. And she was with us for a second opinion. The repeat x-rays with the splint on demonstrate further widening of medial clear space and shortening of fibula. Let me pause for a second and remind ourselves that increased clear space can also indicate coexistent syndesmotic injury in addition to deltoid ligament rupture. So how do we diagnose that? Well, that is difficult to make right now, but it's so simple to decide intraoperatively. First, complete anatomical fixation of lateral mal, which by default restores fibular length. And now stress the syndesmosis. Among several methods to do that, I use a bone clamp to hold the reconstructed fibula and stress syndesmosis under live fluoro in both frontal and sagittal directions. And I look for instability and widening of tibiofibular clear space. When present, fix it with a transverse screw or suture button. Then as the next step, stress the medial structures with the same external rotation stress test intraoperatively to identify for medial clear space widening. In this case, no instability was noted with syndesmotic stress test, while there was instability with external rotation stress test. Hence, the medial side was explored using a straight incision. We identified a mid-substance tear in the deltoid ligament complex, which was managed with a direct suture repair. So this combination of lateral mal fracture with the deltoid ligament rupture is called a bimal variant. In light of deltoid ligament repair, the ankle was protected for 6 weeks, followed by a range of motion exercises and gradual transition to full weight bearing. So when we suspect injury to both deltoid ligament and syndesmosis, we follow what we call as divide and rule approach. Step 1, anatomical fixation of lateral mal. Step 2, check syndesmotic instability with the direct stress and restore when present. And step 3, check medial instability with external rotation stress and fix the problem when present. We can't let deltoid ligament injury go unrecognized and untreated. Let's go to the next step. We have a typical bimal fracture, clearly an unstable pattern. Well, same steps again, anatomical fixation of fibula using plate and screws, and then direct stressing of syndesmosis using a bone clamp. And in this case, there wasn't any instability. Then proceed to medial fixation, make a straight medial incision, protect saphenous vein, and more importantly, saphenous nerve, incise the proximal band of inferior extensor retinaculum. Then the fracture is right in front of us. Tease out the periosteum, which is often invasinated inside the fracture gap and amputated generously around the fracture edges to better appreciate the reduction. Now use a bone hook to hinge open the medial mal over the deltoid ligament and take a peek inside the joint. Give a little valgus to open the joint better. Inspect the talus for any osteochondral fragments. Lavage the joint copiously, and then, only then, reduce the fracture. Because we can't let any loose fragments stay inside the joint. I routinely use a small towel clip to secure my reduction while I do the fixation. I would also make a drill hole in the distal tibia so that the short prong of the towel clip would not slide while I tighten the ratchet. Check the articular reduction meticulously. Then I provisionally stabilized the fracture with an additional K wire, biting the forecortex posteriorly while I insert the first screw. I think the towel clip and an extra K wire are necessary to counter the tremendous torque created by screw as the threads advance inside. With all these efforts, we can achieve an anatomical reduction of articular margin and secure fixation with no spinning of the fragment. I prefer 2 screws whenever possible, but when the fragment is small like this, in this case, I use a combination of K wire and a screw. I think the key point is to achieve a forecortex fixation with both implants. At 3 months post-surgery, the patient had fracture union with good function. The K-wire tip could be felt with the deep palpation, but the patient had no symptoms and was not keen on hardware removal despite being advised. So the learning point in this case is attaining stable anatomical reduction of articular margin is paramount importance in addition to achieving fibular length and stable syndesmotic reduction. I have a couple more cases to go, but I'm happy to stop here and take opinion of the panelists if they want to do anything differently for these cases. Sir, do you do anything differently, sir? So, Mr. Sir, Ravishankar, sir. Would you go in the same sequence, fix the lateral mal?
Srinivas, I have a
Yes,
question.
sir. Yes, sir.
Yes, we often get these cases, whatever the common patterns we get here, all the same here.
Yeah.
But the thing is, often we notice that one complication, I mean, one of the problems we get is most of them are compound. That is one we get.
Yeah.
Secondly, what happens is we get a lot of fractures in especially old people with severe comminution, where it's very difficult to restore the length of the fibula. So in those cases, what could be the best option and what would be the best device to fix? We generally use, of course, 1/3 fibular plate and then, of course, small DC plate rather than recon. And somehow I feel strange to observe the postgraduates doing intramedullary fixation with all sorts of things like rush nail, K wire, everything. So is it justified or not? Because I am against that, and especially regarding the compound nature, regarding the comminution, and regarding the method of fixation for fibula. Please comment.
Yes, sir. We have one more case that has comminuted fibula, but now that you pointed out, let me briefly share that. So restoring the fibula is of paramount importance because the fibula acts as a big strut for lateral displacement of the talus. So the fibula is really comminuted, then we can't believe on anatomical reduction. We have to go for what is functional reduction, maintenance of length, alignment, and rotation without violating soft tissue attachment of fracture fragments. In that case, we fix the distal part of the plate to the bone first, and then use the plate as a reduction tool to push the distal fragment in distal direction until we restore the relationship between medial and lateral malleoli. At this point, we don't know what is normal to the particular person. So we take the x-rays of the contralateral extremity or the uninjured extremity to understand the relationship of fibula. By and large, we say that the distal tip of fibula should align to the lateral process of the talus, which is not true in every case. So the contralateral pictures will serve as a good template, and fixing distal first technique is an additional tool. And open fractures, it's a different animal depending on the complexity of the open fractures. We are duty-minded to do debridement, soft tissue surgery, and provisional external fixation. And earlier concept was to delay the surgery, but present day we have to get the wound cover as soon as possible and then do the definitive fixations.
What about this intramedullary fixation? Have you ever tried? I was a little surprised. I don't know whether it's mentioned in the recent lecture.
So intramedullary fixation, I believe it is only for transverse fractures, axially stable fractures. But nowadays, the intramedullary interlocking nails have come. I believe we Indian population don't have sufficient medullary canal to have a big rod inside our fibulas.
Thank you.
Thank you, sir.
Sir, one more doubt, sir. As
Yes,
you
sir.
commented to take X-ray of the contralateral side, why can't we rely on the ball sign?
Yeah, we definitely can. But as I said, not everyone will have the same relationship. There has been a nice study done over several hundreds of patients to understand the relationship between the distal part of the tibia and the lateral process of the talus. The ball sign is basically an unbroken circle that goes along the lateral aspect of lateral process of the talus, and it should touch the distal tip of the fibula, but it doesn't happen in all the patients.
And what about the Shenton's line, sir?
Yeah, Shenton's line is a good thing, but Shenton's line indicates an unbroken line along the medial side, superior side, lateral side. Even if the fibula is stopped here, still we can say an unbroken Shenton's line. I believe Shenton's line is basically to look for intra-articular incongruity rather than for the length of the fibula. But we don't go wrong by and large if we rely on ball sign and trying to align the distal tip of fibula to the lateral process of the talus in majority of the patients. But if you want to be really precise, then the way is to check the contralateral extremity.
I think we have few questions to take. Naresh, can you just take up the questions? Naresh, are you there?
Yes, sir. I'm just getting it.
Yeah, just can you take up
Meanwhile,
the
you can
questions?
proceed. Meanwhile, you proceed with the local discussions.
Okay. Any comments from other panelists? Atmaram?
Hello. Hello, sir.
Yeah.
Sir, this is Dr. Ravi Shankar.
Yeah.
What's your take on gravitational stress view?
Can you repeat the question, please?
What is your take on gravitational stress view rather than physical stress method?
Yeah, that's a good method. It's an alternative technique to external rotation stress test. It can be done preoperatively in an outpatient setting, but whereas intraoperatively, the patient is in supine position, and perhaps it's not possible to do it unless you are operating on lateral position for other reasons like posterolateral plating of fibula like that. I agree, both are the same.
So,
Leela, you have some questions?
yeah, how about plating on the lateral surface? Lateral surface.
How about plating on what?
Lateral surface of the fibula. I think your plates are on the posterior.
Yeah,
surface.
you see the lateral process, lateral fibular plating in the next case. See, there are only two surfaces for fibula to plate, the posterolateral or the lateral.
Yeah.
Depends really on fracture configuration. If the fracture configuration is something spiral, you can really take advantage of posterolateral plating with an anticlave principle, because that's the best way to restore the length of the fibula. Anatomical reduction and stable fixation will automatically restore the length of the fibula. You can also do a lateral plating, but you have to neutralize. First, you have to stabilize with a lag screw and then neutralize with a plate. In short oblique fractures, perhaps you can pin the oblique fracture configuration with a simple K-wire and do a lateral plating. That's also can be done. But when there is a spiral fracture, I wish I go with posterolateral plating.
Okay. And coming to the repair of the deltoid ligament.
Yeah.
And how easy it is. I mean, you can see the ruptured ends clearly, or
yeah, in indicated cases, soon after you incise the deeper tissues, soon after you incise the proximal band of inferior extensor retinaculum, just like how you see the medial malfracture, you see the big tear running from anterior to posterior direction through the deltoid ligament complex. It's such a big ligament. that it spans from medial mal to navicular, medial mal to syntactile talus, medial mal to calcaneum, medial mal to posterior part of talus. So there is no way that you can miss it.
Sir, which one you prefer, sir? The deeper or superficial or both?
Well, the common injury is avulsion of the deltoid ligament from the medial mal, and it usually involves the superficial deltoid ligament complex. The deep deltoid ligament tear is something very rare to happen, and it usually gets avulsed off from talus instead of coming from the tibia.
Thank you, sir.
So there are a few questions in the live YouTube channel.
Yes, sir.
One question is regarding the syndesmotic screw.
Sure.
So when you put anti-glide plate, and if you notice syndesmotic injury, so how do you put the syndesmotic screw? Tips and tricks how to avoid the fracture.
Yeah, this particular case has syndesmosis. Perhaps we can reserve that question soon after you complete this case, if that is okay.
So that's fine. Another question is on how often do you need to check the length of the opposite fibula to know the normal length? How frequently you check that?
Only in comminuted cases. So this case has comminuted pattern. So I'll check the length of fibula on the other side. If it is in spiral fracture, transverse fracture, short oblique fracture, just do the anatomical plating of fibula. You are sure for 100% that the length of the fibula is restored. You don't have to take the x-rays of the opposite extremity in every case unless it's a comminuted fracture of the fibula or you suspect syndesmosis problems.
Srinivas?
Yes, sir.
What type of implant do you advise in osteoporotic fractures of the fibula? Same
Sir,
method or anatomically contoured walking plates?
Sir, so far I used 1/3 tubular plates that has a locking design. Okay. Also the 3/5 Recon LCP that I just showed, that has a locking design again. And the market is ready for other kinds of anatomical lateral locking plates. And there was something routine in the US. My experience with that is only for 1 year during my fellowship, and everything do well. But given the preference, I would go for a simple 1/3 tubular plate or a small Recon LCP because the profile is so thin, so soft, and it's simply malleable. And I think it is very gentle to soft tissues.
Sir, one rare condition, maybe. In case the patient doesn't have a limb other side, or if there is some malunion already, because it is India, okay, most of the people go to bone setters. In such situation, what you prefer?
Yeah, I follow your technique, Dimes method, Dimes sum.
Yes, I think you can move on to the next case.
Sure. Yeah, we have a 45-year gentleman with a medial mal fracture and a distal fibular fracture happened proximal to the level of syndesmosis with additional comminution. We know that such a fracture fragment patterns are highly unstable due to damage to medial pillar, lateral pillar with possible syndesmosic disruption. And each of these have to be individually addressed during surgery. So again, we start with lateral fixation. Since the fracture is quite proximal, we are mindful to identify the superficial peroneal nerve, dissect it along the entire length of the incision and protect it throughout the surgery. We know that comminuted fracture patterns, as just discussed, need functional reduction instead of anatomical reduction. So to remind ourselves, functional reduction is nothing but restoration of length, alignment, and rotation with no violation of soft tissue attachments of the fracture fragments. So bridge plating of fibula has been done, followed by syndesmotic reduction and stabilization using a 3-5 cortical screw through the penultimate plate hole distally. When I suspect syndesmotic injury, I'll make sure that I'll do the lateral plate. Finally, the medial fixation was performed using 2 screws in standard bicortical fashion. And the follow-up X-rays at 3 months demonstrate satisfactory fracture union with good callus and anatomical restoration of ankle mortise with good function. So the 2 key points in such fracture patterns where the anatomical reduction, I think I'm jumping slides, I'm sorry. So the key point should be discussed here. 1, fibular length, and 2nd, syndesmotic reduction. As we just said, unlike in simple fracture patterns where anatomical reduction of the fibula guarantees restoration of the length of the fibula, the comminuted fractures have an inherent tendency to shorten. Also, achieving syndesmotic reduction can be quite challenging, even if the length of the fibula is accurate. Syndesmotic malreductions can still happen. So let us study this axial CT slice at 1 centimeter proximal to the ankle joint. Normally, we can find a nearly equal gap throughout the incisura. And malreductions can happen either in anterior direction or posterior direction, or even over-reduction, once thought impossible to get, can still happen with the powerful jumbo King Kong reduction clamps. Or the fragment can external rotate, or can internal rotate. Any kind of malreduction can happen even after achieving fibular length. So how do we obtain the best of both worlds? In other words, we need a girlfriend and an understanding and pleasant wife. Is it possible? I mean, we want to achieve fibular length as well as syndesmotic alignment. To solve these, the fluoro pictures of contralateral ankle can be extremely helpful to serve as templates. These images are typically obtained in the operating room before prepping and draping the part, and these images are saved in the monitor. The first one is the mortise view that helps to understand the fibular anatomy. So what do we see here? The vertical relation between the distal tip of lateral mal and lateral process of talus can serve as a reference to fibular length for that particular patient. While the profile of lateral mal helps to understand the rotation. We can also measure the tibiofibular clear space as a reference to syndesmosis, but this can be better noted in lateral view because the instability of syndesmosis lies predominantly in sagittal plane. So coming to the second image, is called a talar dome lateral view, which is a lateral Siam picture of the uninjured ankle centered onto the talus with perfect superimposition of medial and lateral borders of talar body. So what do we see here? We know that the distal fibula overlaps the distal tibia, and we measure the distance from anterior fibular border at the joint level to anterior tibial cortex, which serves as an indicator of distal fibular position within the deepest portion of tibial incisura. These 2 images of uninjured ankle function as excellent templates. During surgery, we obtain the same mortise and talar dome lateral views of operating extremity and compare with these 2 templates to ascertain fibular length and syndesmotic reduction. This method was published in 2013, which is reliable and reproducible. So we have one last case, if you are not tired yet, and I'm happy to take the questions.
So any questions on the panel?
Srinivas,
Yes, sir.
the syndesmosis screw, you fix only 3 cortices or 4 cortices?
3 cortices, sir.
Only 3.
3.5 mm.
Only single
Yeah,
screw.
tricortical single screw. This was my experience prior to going to the US. But I have seen the young athletes in the US who are at high demand, and I have seen my mentors doing 2 screws as well. But if you put 2 screws, you have to remove both screws before full weight bearing and before full functionality by 3 months or so. So if you put 1 screw, you have to remove only 1 screw. And I have also seen doing the suture button technique, tightrope. And I have also seen a combination of tightrope and cortical screw. I think the key is getting the syndesmotic reduction, as I have seen in the clip arts, the various combinations of mole reductions that can happen despite maintaining the good fibular length.
How much force you use to reduce the syndesmosis joint, sir?
I think I don't apply any force at all. Once you reduce the fibula,
You just sit like that.
Yeah, if it is a fresh case, and I don't hesitate to dissect anterior to the distal fibula to directly see the syndesmosis. And you can see the anterior lip of incisura directly, and then you see a thin groove. Maybe you may not appreciate the posterior incisura, which is actually more prominent than the anterior groove. So you can slide the distal fibula from over the anterior incisura and get it back to deepest portion of incisura until you have a hard stop over the posterior lip of incisura. So you can have a good feel about how much you are translating in sagittal plane, which you can feel it, and with the simple dissection here, you can also visualize it. And of course, fluoroscopy is there always to make sure that we are in the right place.
Any comment on Church's test, sir? Church's test. Any comment on Church's test? Intraoperative fluoroscopy by dye.
I have no idea, Jahangir. You can explain.
So there is a test known as Church's, CHERSTEY. Church's test, in which intraoperatively you will inject a dye into the syndesmotic joint through the anterior inferior tibiofibular area, or into the joint line, lateral joint line. So if the syndesmosis is good, once after reduction, it won't disperse above. It just spreads into the joint. We can see the joint line clearly. But this has some false negative and false positive patterns also. If it is rupture, if there is more rupture of the ligaments along with that interosseous membrane, it definitely spreads above.
Sure, makes sense. Yeah. That looks like a good test. Yes, sir.
This is Achyut.
Hi, Achyut.
My tendency is to plate the fibula always posteriorly. That is the posterolateral.
Okay.
For many reasons, I feel that is more stable. I get double cortices in the distal fragment, where hardly we get 2 screws. So that is the most favored position. In a comminuted where you want to put a syndesmotic screw, do you always prefer a lateral? Can we still do a posterolateral and then put the screws outside the cortex, outside the plate? What's your opinion? What's your take?
Well, if it is a comminuted fracture and I'm operating everything in supine position, then I prefer a lateral plate, because with that I can fix to the lateral surface of the lateral mal distally, and then, as I said, distal first technique, and then I use the plate to push the distal fragment until I see the normal relationship here, which I also cross-check with the images of the contralateral extremity, and then I stabilize the proximal part. And I deliberately leave a couple of holes at around 2 centimeters proximal to the level of the ankle joint to be able to utilize for syndesmotic screws. That's my take.
How about sticking to the posterolateral plate itself even
Yeah.
in a comminuted where you want to put, because it has got its own advantages, whereas where your distal screws always get a double cortex.
Bicardia. I do that definitely. If it is a posterior fracture dislocation, if I'm operating the patient in a lateral position or prone position, then I take the advantage of placing the plate posterolateral or posterior, and then fight the screw outside the plate.
Yes. Because the posterolateral plate offers many advantages.
Sure.
Not
Sure.
just anti-glide, it offers many other advantages.
Yeah, makes sense. Yeah, minimal soft tissue. But another point is, if the fracture is quite low, then we have to be really careful because we can't really encroach the plate onto the domain of peroneal tendons. You have a superior peroneal retinaculum, which you have to respect. In an attempt to put the plate, often we tease off the superior peroneal retinaculum. That will cause postoperative peroneal tendon subluxation. So every technique has got plus and minus. But I totally agree. Posterior plate or posterolateral plate has got the best advantages. Well, you see this case where the same thing whatever we discussed.
Right.
Srinivas, what is the best time to remove the syndesmotic screw?
So around 12 weeks before the patient resumes to full activity with no limitations, like maybe around 12 weeks.
Okay.
Is it compulsory to remove the screws, or you remove if it causes any problem?
Well, if you retain the screw, it will not allow physiological toggle at distal tibiofibular syndesmosis, which is necessary. Theoretically, there is 1 to 2 millimeters of motion at this point with the range of ankle motion. So we need to let the ankle move not only at tibiotalar, but also at tibiofibular level too. I routinely remove the screw at 3 months because it's only tricortical. So if it breaks, then I have to leave the other portion of the screw inside the bone. If it is 4 cortical, then you have the advantage of taking it from the medial cortex, even if it breaks.
In reversive fractures, the high fibular fractures.
In Mason fracture, yeah.
Can we get away just by putting syndesmotic screws, or we want to fix the fibula as well?
No, that's a very good technique. You just reduce the fibula, you pull the fibula, you take a towel clip and make a percutaneous bite on the anterior and posterior margins of the fibula and pull the fibula and try to restore the dime sign and align the lateral process to the distal tip of the fibula, and also compare with the operating extremity. That's important here because even if you restore the length of the fibula, it can be either anterior or posterior. We just discussed that, right? So we have to really study the talar dome lateral view of the contralateral extremity as well as the injured extremity. Once you are happy, then you can provisionally pin with a couple of K wires and then do a percutaneous stabilization. Yeah, that's one of my publications in IGO.
Srinivas?
Yes, sir.
In diabetes, what is your protocol and what are the precautions you will take?
Diabetes is another big animal, sir. D stands for double fixation, double the time for immobilization. So even if there is no syndesmotic instability, we put cross tibiofibular screws, and we definitely use locking plates. Before we embark on any surgical treatment, we make sure that the soft tissues are really soft and supple. We see the positive wrinkle sign. We also make sure that that foot is vascular. We don't hesitate to do Doppler, and we also take opinion from angio, because in countries like US, where there's a lot of scope for litigation, if something happens after the surgery, then the practice is done. So I've seen my mentors referring the patients for vascular colleagues to look at the vascular studies and do angio and that kind of study. So first we check the vascularity. and then we check the soft tissue status, and then only we push the patients for surgery. And even in stable ankle fractures, we fix them. So I repeat, in diabetics, even in stable ankle fractures, we fix them because of high chances of getting Charcot. So we fix them, and the fixation is a double fixation in the sense that if the soft tissues permit, it will be a lateral plate as well as a short anterior plate or a short posterior plate. If it is a single plate, then you will have additional fixation going across the fibula and tibia, as I said. And just because we had good fixation, it doesn't mean that we can allow weight bearing, just like in non-diabetic people. So we protect the extremity for at least 8 weeks to 12 weeks, and then we resume weight bearing with the help of a cam walker boot for another 4 weeks, and then gradually transition. And even if the patient is out of the boot in 3 months or 4 months, then we still give a protection brace for another 2 months. So only after 6 months, we let the patient to walk with no assistive devices. I know it's a bit overkill, but any kind of instability is going to land up with Charcot. And once Charcot has started, then I think that's a big problem.
What about,
I'm sure you will have more tips about diabetes people, sir.
what about fractures associated with severe soft tissue injuries?
Yeah, that's a problem with ankle fractures. They already have meager soft tissue envelope, and in addition, if you have soft tissue damage, so if the joint is dislocated, then that's an indication to do an external fixation, just to maintain the tibiotalar alignment in both coronal and sagittal planes. If the joint is not dislocated, perhaps we can restrict in a splint with frequent monitoring with follow-up x-rays, just to make sure that it's not displacing. We also examine the skin. We take the limb out of the splint and check the vascularity intermittently, check the soft tissues, and then do the surgery whenever the time comes.
Do you advise ablation expects initially?
Unless there is a fracture dislocation. If there is no fracture dislocation, I think the splint would suffice.
Yeah. Any more questions from the panel? If not, I think that's a great lecture and the case series. Thank you very much, Srinivas Garu, for bringing out the nice cases and relevant points out of it. You stay back and then we'll go to the next lecture. This is a brief video presentation by Professor Atmaram Adishesh from Anantapur.
Sure, I'll hold off this last case then.
So you have one more case? Sorry. So if you have one more case,
yeah, this is.
Yeah, please go ahead.
Last case, but I'm happy to hold off if Dr.
No, we have enough time.
No. Carry on.
Okay.
Carry on.
Sorry, I thought we have finished the cases. Okay.
Okay, sir.
We'll go ahead with
the case. Yeah, these are the radiographs of a 32-year-old man who jumped off a wall and fell. Here we can see a fibular fracture just proximal to the level of ankle joint, obvious widening of tibiofibular clear space, and a small posterior malfracture. In such cases, we should be mindful to also look for other injuries, such as osteochondral of the talus, loose bodies, fifth metatarsal base fracture, anterior process of the calcaneum, and lateral process and posterior process of the talus, and also injury to the peroneal tendons. So coming to the management, similar lateral approach to expose the fibula. There was an obvious disruption of anterior soft tissues here with a defect in the syndesmosis. And then I continued my fixation like this. By now you would have got a sense of how much I like anticlide plating for such fracture patterns for the obvious reasons that were just discussed. Then syndesmosis was reduced and stabilized using a 3-5 cortical screw, but this time outside the plate. So let us see the post-op X-ray. Does everything look good? You can comment ruthlessly. Looks awesome or awful?
Sir, there is still middle space more. And why was the posterior malleolus left?
There was no posterior fracture dislocation. It was not an inherently posteriorly unstable fracture. There was a trend to come from the back for all the cases and explore the posterior mal, but now we have come to a right balance where we explore posteriorly only if there is a posterior fracture dislocation to begin with, not in every case. So that was my take on that case.
Sir, I feel we have an undisplaced fracture of the medial malleolus.
Do you think so, sir?
I don't know.
Maybe.
That might be a shadow, sir, actually.
Okay.
Can you see such fracture here? I apologize for the poor quality. These x-rays from ages ago. I agree with Jahangir. It looks awful for two reasons. There is an obvious medial clear space. And how about the fibular length?
So dime sign, you can see it is slightly migrated up.
Yeah.
And there is a mild disruption in the sentence line.
Yeah. So where do you see the disruption in the sentence line?
Just 1 or 2 mm, sir, here.
Okay.
Yeah. Just
it is squeezed. It is squeezed, right?
Yeah.
Yeah. This should have been here.
Yeah. Yeah. And also maybe rotational problem with the fibula.
Okay. Okay. I think all those points are very valid. Thank you, Jahangir. But my question is the fibula really short? I opened it and I saw the reduction and I stabilized it completely open. So it's an anatomical reduction. It's an anatomically reduced fracture. Should not technically have a short fibula, right?
Yeah.
But it appears short because it is more reduced at syndesmotic level due to posterior translation. I repeat, due to significant posterior translation in relation to tibial incisura. So it's an apparent shortening. It's not a true shortening. So here comes the learning point. Medial clear space widening after anatomical stabilization of fibular fracture, once thought due to deltoid ligament interposition, is now believed to commonly occur as a result of mal reduced syndesmosis in the sagittal plane. This requires an immediate revision. We can't let any syndesmosis stay mal reduced like this. However, for unfortunate reasons, the patient denied further surgery and was lost to follow. Maybe one of you guys would have seen this case.
Sir, some literature says that if you remove the syndesmotic screw, sometimes it may get reduced.
Well, if that really happens, then we are really, really lucky. But I don't think it will happen because the inherent tendency for the distal fibula is to translate posteriorly because of the gravity. So these are the anterior syndesmotic ligament and intraosseous ligament, which are holding up in the neutral position. So that's the same take on for the other company that has come up with the suture button. They say that the suture button is something flexible. Some technical inaccuracies can be okay. It's a forgiving implant. Even if you have little mal reduction, then it is okay because it's going to bounce back. It's not a rigid implant. But my question is, why do we have to really struggle with the technical inaccuracies? We know how to manage this syndesmotic injuries very well now. We have uninjured extremity x-rays serving as templates. We have read so much. We have done so much research in this. So why don't we really focus on anatomically reducing the syndesmosis? Why do we have to really depend on the grace of an implant?
Sir, here one point is, there was a posterior malleus fracture. Is that? Second thing is lateral X-ray. If you take, usually measure, some people measure the anterior cortex of the fibula and the anterior tibia distance. Few measures the posterior. Usually they divide into 5 parts, and the last 1 part should be in correlation to the contralateral side. So in such cases, why shouldn't we fix the posterior one? If you want accuracy in case of
when there is a posterior malleolus fracture, it's better to take the anterior distance. Even if there is no posterior malleolus fracture, why not we get habituated to measure the anterior distance all the time so that everyone knows what to look for it. So that's my take on thinking about anterior measurement than the posterior measurement. Then I don't understand the second part of the question. If you can please repeat.
To take the contralateral side, same sir, same. The measurement between that. And how often we take CT, sir, in posterior malleolus fracture, CT? Because the new literature says that it's always better to take a CT in posterior malleolus fracture.
Sure, of course, there is no harm in taking a CT. CT will definitely give more information to understand the 3D orientation of the fracture. We can precisely plan the plate placement and the screws direction to be able to insert them perpendicular and orthogonal to the fracture area. That's it.
Same time, we can know how much displaced, in which direction either syndesmosis has injured and which direction the fibula has been displaced.
Of course, no doubt. I totally agree. But if it is something not greatly displaced and it's not a fracture dislocation to begin with, and you are not thinking about any central depression fragment like pilon fractures, perhaps I'm okay to go ahead without surgery, without a CT scan.
Thank you, sir.
Srinivas, what is the real indication for posterior malleolus fixation?
Sir, posterior fracture dislocation, sir, regardless of the size of the posterior malleolus, if the injury films show that, or if the patient comes with an obviously deformed ankle where the foot is displaced posteriorly, that gives me an indication that it is an inherently posteriorly unstable fracture. So regardless of the size of the posterior malleolus, I go posteriorly to fix the posterior malleolus because that gives the best biomechanical advantage to counteract the initial posteriorly directed vector forces. And we know that fixing the syndesmosis through fixation of posterior malleolus is the best way of stabilization. But be mindful that despite fixing posterior malleolus, you can still have anterior inferior tibiofibular ligament rupture, interosseous ligament rupture. So we still have to stress the syndesmosis, and depending on the instability, we still have to add additional screws or tight rope or suture button. So we really don't take it for granted that we have done the fixation of posterior malleolus. It means that we have securely stabilized the syndesmosis. That statement is incorrect.
If the fragment is big enough, you use a buttress plate for the posterior malleolus?
So if the fragment is small, I use a simple 1/3 tubular plate in an anti-glide fashion. If the fragment is big, sometimes you see that the fragment is like a triangle extending right onto the posteromedial part. Then I use a simple T-plate. Another technical tip is you have the 3.5 mm distal radius T-plate, which you can reverse and fix it because it has a nice contour and it is quite malleable. We have a few summarizing points. So to summarize, 4 things would decide the final outcomes following ankle fractures. Number 1, anatomical reduction of articular margin. Number 2, successful restoration of fibular length. Number 3, attainment of medial stability. And finally, attainment of syndesmotic reduction and stability. So this point is important. Attainment of anatomical syndesmotic reduction and then stabilization. Nonetheless, why do we really strive to achieve all these four? It's basically to stabilize the talus well within the ankle mortise until healing of fracture and damaged ligaments have been accomplished. That is the only way we can re-establish the normal contact area of tibio-talar articulating surfaces, which can at least delay, if not prevent, the onset of ankle arthritis. We learned from the landmark study by Ramsey and Hamilton, published way back in 1976, that talar displacement as little as a millimeter can compromise 40% of contact area. This has been retested after 30 years using modern techniques, which had confirmed the same statement. So in all unstable ankle injuries, let us all put our stringent efforts to maintain the talus within the disciplines of ankle mortise. Thank you. I'm happy to take any questions you have.
How much of the tibio-fibular dynamics is altered if you leave the screw at the time of weight bearing?
So 1 moment. Did I stop sharing my screen?
Yeah, you stop the sharing. Please go ahead, sir. Yeah.
Okay. Yeah, 1 second. Can you please repeat the question?
Yeah. I am also a strong proponent of removing the syndesmotic screws.
You are a strong proponent?
Yeah, I'm a strong proponent. But there are arguments which say that it doesn't really alter the dynamics of the tibio-fibular joint. Even if you leave the syndesmotic screws, you can still weight bear. So,
I think it depends on the timing of removal of the screw. When would you routinely remove the screw?
Yeah, we usually by about 10 to 12 weeks.
Yeah, I think I'll do the same. If you leave it too long,
before the patient starts weight bearing.
Yeah, that makes sense. Yeah. What can happen if we leave it too long is the risk of having a fibrous union that will not allow the physiological between the fibula and the tibia. So that would compromise the function. Hence, there is a tendency to remove the screw even before 12 weeks. Like I have seen few orthopedic surgeons in the US removing at 8 weeks or even 6 weeks. They say that the soft tissues, they take only maximum 6 weeks to heal. So why do we have to leave it for 12 weeks? Maybe the answer is right. Why don't we try to retain the screw for just 6 weeks and then start removing it from 6 weeks? Maybe that might change the biomechanics. Ultimately, what we are trying to see is the purpose of the screw is a positional screw. It's only to help the ligaments to heal. And we are relying on the patient's ability to heal the ligaments. We are not we're not using any suture anchors, or we're not opening the syndesmosis to directly repair the torn ligament like what we do for deltoid ligament. So we really can't answer to our patients. That's their healing potential, unfortunately, that they are unable to heal the torn ligaments.
Naresh, are there any questions from the viewers?
Nothing on the YouTube, sir.
Okay. Skip the videos of Dr. Atmaram. Then Dr. Jangir will present his cases.
Okay. Jangir, are you ready with the cases?
Jangir, are you there?
Yes, sir.
Yeah. Share your screen.
Sir.
put it full screen, Jahangir.
Sir, trying, sir. Yeah.
Yeah. No, got it.
Thank you, sir. So this is a X-ray introp. So this is I don't have this pre-op X-ray. So it is an introp fluoroscope X-ray. So what are the problems in this we see? So as I marked here, we can see it is a fixed fracture. There was this was the initial day of my practice when I did this. So there was broken sentence line, and there is no overlappment of the tibio on the fibular contact area, and the Dimes ball sign is negative. Because all this happened here due to comminuted fracture of the fibula, and a very short plate was used, and it was a lateral plate. So what I tried is I tried to compress the fracture. I was more keen in reducing the fracture. I was trying to unite the fibula and forget the importance of this. So I thought there was a clear medial joint space. So what I tried is I tried to put a screw, one more screw, then it became more horrible. The space was increasing. So the Dime sign negative, but there was compression here. Later what we tried is we have to go for revision surgery, remove all these screws in 3 days. Then these screws were maintained, and we have to maintain the length. We have to use a little bone graft. In this case, I used a little bone graft to maintain the length because there was more gap there. And then I didn't check the contralateral side X-rays. I didn't take that. I maintained this, and finally we got good reduction. So I didn't have the post-op X-rays also. But this is one more case. This is a 23-year-old male RTA. There are no comorbidities. And this is the clinical picture of the fracture, what happened. So this is the pre-op X-ray. Obviously, it is supination and external rotation. Sorry, supination adduction. So this was the post-op. Usually, I used to fix this. I have checked I have done the hook test intraoperatively. The joint was stable, obviously, because it is supination adduction, and I usually prefer fixing the joint with this external fixator so that the soft tissues has to heal. And this is the post-op X-rays after 3 months. Patient is happy, walking. No. Any comments, sir?
I think given the complexity of the injury, it has been very well managed with very minimal internal disruption. Trying to stay away from big plates and combination of plates and screws and plates on. I think that's a very good outcome. You have a lateral view as well?
No, sir, I didn't. Actually, it was taken in 2016.
Okay, I agree. Yeah. Sir. This looks like a transverse fracture, right?
Yes, sir.
Okay, yeah. That's a very good technique of using. I believe this is a 3-5 screw.
Yeah.
3-5 or 4-0 screw, I think.
So, pardon me, sir.
Is that a 4.0 can?
4.0, sir. 4.0.
There is one more technique of using 3.5 regular cortical screw, which can go through the medullary canal because it's very flimsy. 3.5 it can auto bend to the tight dimensions of the medullary canal. Okay. But as you said, it is mainly suitable for axially stable transverse fracture patterns only.
Thank you, sir. So this is one more X-ray. 47-year-old female patient with she's a known case of diabetes and 2 months old, but her diabetic condition is stable, always under control. And this is a 2 months old fracture managed elsewhere by a bone setter. What are the comments on the X-ray? So we can see a clear medial space in this condition. Excuse me, sir. Thank you.
Any pre-op later you, Jahangir?
Sir, letter missing, sir.
Okay, okay.
So in this case, what I did is I have used a lateral plate. Most of the times I prefer lateral plate. So and locking. Here I have to maintain the length. As if you see, the dime sign here is not correlating. When compared to the other side X-rays, it is normal. Maybe the fibula on either side, the tip of the lateral on the other side is little high. So it is better to rely on the lateral X-ray. Second thing is, I try to reduce, I put a syndesmotic screw, but after all doing this, in intraoperatively, when we open the medial side, okay, just pronate the limb or eversion, there is opening of the medial joint line. So what I did is, I tried to repair, open the medial side, but the dental ligament is so fibrous, already 2 months. Then I did is I took palmaris and then passed through this curved K-wire, and then through this I have passed it and then fixed this through the talus. I have used here I have looped the palmaris so that it will becomes the deep tendon, and it was stable. And this was the X-ray taken after 2 months post-operative.
This looks.
Comments, Srinivas, about this technique?
Sir, before we go to deltoid ligament, perhaps this screw can be a little distal. The reason
syndesmotic screw.
The syndesmotic screw can be a little distal. Ideally, it should be at 2 centimeters proximal to tibio-talar joint. You can place this screw anywhere between 2 and 4 centimeters, but trying to keep it as close as 2 centimeters would be ideal because it is close to this and it will not affect the tibiofibular joint. Actually, we have a joint here, tibiofibular syndesmosis. We don't want to pass the screw within first 2 centimeters of the distal tibia. So this is slightly higher, and this seems to be a very innovative technique. So I personally haven't done, rather I've just read about it, and I appreciate Jahangir for doing such complicated cases. And
actually, on that day we brought this endo button, sir. Unluckily, our sister has left it down. So no other option to go with this.
Okay. What's the diameter of this bone tunnel?
So pardon me, sir.
The diameter of this bone tunnel?
Bone tunnel, it was 6 mm, sir.
6 millimeters, okay. And would you routinely remove this tenodesis screw?
No, sir, no.
Okay.
If it causes irritation, anything like that,
then we can.
Yeah. Then we can.
Yeah. So in the when you don't have this endo button, what is the other way to repair this deltoid ligament in such cases?
Sir, we can use palmaris or gracilis.
Okay.
And we can use endo button along with that. Sometimes interference screw on either side, up and below.
Okay.
Or a cortical button. Yeah, I mean, they both are the same. And also an allograft.
Yes, sir.
If it is available.
Okay. Proceed, Jahangir.
Sir, thank you, sir. And this is a 37-year-old male patient, 1 month old fracture. So this also managed somewhere by a bone setter. Patient didn't come immediately. So he has to come after a few months. So this was the surgery done. Okay. There were some bone pieces left anteriorly. I didn't explore much as the skin condition was not good. So I used a reverse technique. So plate medially and screw laterally. Joint was very stable, and this was the X-ray taken after 3 months of the post-operatively.
Any posterior malleolus, Jahangir, in this?
Yes, sir. There was posterior malleolus fracture, but the joint congruity is good. So I have tested dorsiflexion and the plantigrade positions along with the plantar flexion. The joint was very stable. And this posterior fragment was very old fragment, and it was so fused, so I didn't try to reduce and fix it.
If it is a fresh fracture, do you advise fixation?
Yeah, usually any posterior fracture, posterior malleolus fracture, I used to fix, sir. Either it's a plate or a screw with washer.
Screw from anterior posterior or posterior to anterior?
Posterior to anterior, sir.
Percutaneous, or you want to open and then do it?
Most of the time I open, sir, because in posterior malleolus fractures, yeah, I go posterolateral plating for this fibula, and at the same time I will check this posterior inferior tibiofibular ligament straighter, try to pull this so that the fibula get reduces, as the incisura is shallow anterior and deep posteriorly. With that, the rotation also will be maintained. Thank you, sir.
Right. You have finished your cases?
Yes, sir. Yes, sir.
Okay. About all the other panelists, do you have any cases? Achyut, are you there?
I'm there.
Yeah. Do you have any cases or anything to take?
Sir, Jahangir, about that screw that you are putting in lateral malleolus.
Sir.
I very rarely do or did not do till now. How stable is it? How prudent is it?
Sir, depends upon the pattern, sir. Lateral malleolus, you're asking, sir. Screw.
A screw, an intramedullary screw into lateral malleolus.
Yes, sir.
What's the idea behind it?
Usually, lateral malleolus, I prefer putting, if it is below the syndesmosis.
Okay.
I usually prefer putting screw, sir, because here, in this case, the joint is more stable when compared to the other, either B or C. So putting a screw gives me more stability there. And usually I prefer 4.0 or 4.5. So sometimes I used a bigger screws also in case of old people where this canal size is very big.
Okay.
Jahangir,
sir.
The only problem with intramedullary fixation is when you want to stabilize syndesmosis. Then how do you do it?
Sir, that's what, sir. I prefer only doing in this case of Weber's A, where the syndesmosis is more stable. Before that, first I will try to go for reduction, sir. Reduce under CM guidance, image intensifier. Then I put a screw. There's no harm in putting in that. Then I will check the stability of the syndesmosis by hook test. If it is unstable, I will definitely replace the screw with a plate. If it's stable, then only I will keep it there.
The problem with, for me, the problem there is the length, the fixation, the stability, the rotation.
Yeah. Yes, sir.
This particular fracture at that level in malleolus demands all these three things.
Yes, definitely.
the rotation, the length,
Yes, sir.
and the stability of fixation. That is the very point why I was telling previously. Even I don't prefer putting a lateral plate also. Frankly speaking,
Posterolateral.
where are you going to put the screws in the lateral malleolus? How are you going to get a double purchase? So when you are using an intramedullary screw, are we getting the three things? There is a risk or jeopardy of the three things: the stability, the rotation, and also there is a risk of injuring whatever soft tissue structures to the tip of lateral malleolus.
Sir, usually I repeat. Usually we prefer putting the screw only in case of stable fractures. So below the level of syndesmosis Weber's A, usually the joint is more stable. Syndesmotic injuries are very less. In that condition only we have to prefer the screws.
Okay.
Preference of the selection of the fracture and selection of the instruments should be depend only intraoperatively. So if we prefix our mind and go with the fixation, that is a dangerous thing. So we will come with bad results. Here, if you see all the X-rays what I have shown, the fracture level is below the joint line. Yeah. So there is high chance of stability. If you just reduce it, it will get stabilized. As these are very old fractures, I have to open them, reduce, and then fix it.
Right. Srinivas, what are your array of implant fixation in lateral malleolar fractures, starting from a small fracture which is below the joint line? Can you please list out, starting from a K-wire to tension band, what are all the array of things which you regularly use?
If it is a low-level fracture, very distal fracture, and if there is no medial instability and the external rotation stress is negative, then that is the case for non-op. If the implant is weight-bearing, we can just use a brace and allow the patient to weight bear because it's a stable fracture. In case if it is at the level of the syndesmosis, and then the thing comes in terms of external rotation stress test, and if the patient has medial clear space widening, then I would prefer using a plate. And the position of the plate, as I said, depends on the fracture configuration. If it is a spiral fracture, an oblique fracture, I prefer a posterolateral plating to get my anti-glide principle to restore which automatically restored the length of the fibula, which is of paramount importance. So comminuted fracture, then I will go ahead for lateral plating. I have not tried screws, intramedullary screws. I have not tried K-wires. So using a 1/3 tubular plate or a Recon LCP, and recently in the US, I have used this anatomical 5 LCPs made from concretes. They're all lateral plates. They're not posterolateral plates.
I will give my array of things what I try to do. If it's below the level of the joint line and the fracture is very small, try to do a tension band wiring, modified tension band. Then going above, I would most of the times do a posterolateral 1/3 tubular plate. If it is osteoporotic or if the distal fragment doesn't give me a good fixation, I would prefer a 3.5 locking reconstruction plate. If the fracture is the intramedullary canal can give me the reduction, I would go with a nail if the fracture is quite proximal, say 4-5 centimeters where the canal is narrow. So these are my array of implants. So I found it interesting, and I tried to find the logic of how this intramedullary screw would help. So that was the point of me bringing this point here.
Sir,
it is a standard technique using a 3/5 screw for distal level fractures. You see a combination of medial malfracture and a lateral malfractures. Being a bimal, it is an unstable fracture pattern, you have to stabilize it for sure, even if there is no lateral instability, even if there is no syndesmotic instability. Using an intramedullary grade 3-5 screw is a standard technique in the US. You can also use a 4-0 screw as long as it's not a comminuted fracture, as long as it's not associated with the you, after all, making a small nick to the soft tissues and going to the lateral abdomen and making a drill hole of 3.5 and 4 millimeters. You are not opening laterally, which has very poor soft tissues. You are not risking superficial peroneal nerve. And you are not risking the problems of having hardware irritation with the large plates. And even with posterolateral plate, sometimes we may have to bring the plate so distal, which can irritate the posterior tendons. And it's quite possible to have a tail of posterior tendons, peroneal tendons as well. So given the right indication, I don't see a problem using an intramedullary screw.
Srinivas, I have a question for you.
Yes, sir.
Yes, see, leave alone the fracture pattern, bimalleolar or single malleolus or posterior malleolus together. Okay, fine. Given the choice, if we have to fix only a single bone, would I fix only fibula? Our teaching was that fibular fixation is the most important point in management of any ankle fractures.
Length.
So does it still hold good, or there is some change? We believe that best fixation of fibula will bring about the best results in ankle fracture management. Does this statement still hold good?
I think so, sir. Best fixation of fibula in the sense, best restoration of the length of
Yes,
fibula.
that's what I meant. Yes.
You can get it with an intramedullary screw because it's already an axially stable fracture.
Yeah.
Yes, if it is a comminuted fracture, whatever you said is right. We believe in restoration of the length, functional reduction. That's the main buttress against lateral translation. We know that as little as a millimeter can change the contact area by 40%. So we have to get the length right.
So all efforts over the fibula first. Is it still?
Two things. Yeah, the first point is what you said. What I really want to emphasize on the second point is, despite getting the anatomical restoration of the fibula, we can still have malreductions of the syndesmosis, which is not seen in AP view. You can still have normal tibial space. You can still have normal tibiofibular overlap, but in the sagittal plane, the whole distal fibula can be either anterior or posterior. So I just want to add an extra point to that. So we focus on lateral man for sure. And then we also focus on syndesmosis to ensure that it is stable. If it is unstable, we first reduce it anatomically, take the contralateral pictures as templates and try to reproduce closest to the anatomy. Little bit of 2 millimeters should be okay, I think. That holds very true. My pleasure.
Srinivas, what is your take on distal anatomical fibular plates? Nowadays, the 2.7 system also has.
Yes.
What is your experience?
They are very versatile, sir, especially for low fractures, comminuted fractures. If you want to have multiple points of fixation in that flimsy cancellous bone of the lateral mal, then I think that's a very good device. It also have polyaxial locking mechanisms.
Yes.
But the only point is we have to put every screw under fluoroscopic control in order to not to violate the articular margin. So that's the only point.
Sure. Panelists, sir, anything to add? Other Ravi Shankar, Someshwar Reddy, sir. Atmaram is not there?
I'm here, sir.
Yeah. Your experience, share with us.
See, like we have go with the conventional method, like Raghunandan sir has told. I always plan to fix the fibula first, length second, and try to see the syndesmotic screw, syndesmosis stability. If needed, put a screw or not. First, up till 2003, 2004, we were mostly going through a lateral plate. After 2003 and 2004, we started going through the posterolateral side. And when we have a bimalleolar fracture with a spiral fragment just above the level of the syndesmotic screw, what we have been doing is we put the patient prone, not lateral, and open the fibula posterior-medially to the fibula, put a plate, and if there is a small fragment in the posterior-lateral part of the tibia, that can also be assessed, addressed. My vocabulary is very accurate. First, I will assess it, assess the piece, and then address it. It can be either in the form of a single screw with a washer, or it can be a T-plate. Both will be done in the same incision. And in the same position, I go on the medial side, open it, and try to put the screws. So I don't, try to put the patient again prone. This is the way I used to do it. And one thing which really struck into my mind is F for fibula, F for first. So fibula first, and the length and everything of fibula is the first. That will maintain your first, what we are taught, and it has stuck to my mind, is it will restore the length of the ankle mortise. And this will bail you out even if you have comminution also, especially even in pylon fractures. I would first address the fibula first than anything else, because it will give you the length of the ankle mortise. You can always compare on the other side and do that. And rest of the follow depends on whatever hardware you are used to and whatever is available. So we improvise and we fix that. I think the basics are basically maintained, and then rest is all improvisation. What do you say, Srinivas?
Yeah, I'm happy with your technique, sir. My only concern is if we don't predetermine for posterior exploration of the distal tibia, we can do everything in supine position. My only indication for prone position is posterior fracture dislocation, regardless of the size of the posterior. In those cases only, I routinely do it in prone position, standard post-lateral approach to expose the posterior distal tibia as well as the posterior portion of the lateral. And at that point, I start with the distal tibia first, and then address the lateral manner. I don't develop two separate intervals on either side of the peroneal tendons. Rather, I go through one interval between peroneal tendons and FHL and look at the peroneal artery and preserve it throughout the surgery. And then finish up the tibia and finish up the fibula. And if the patient has medial mal, I expose it in the same position. And it will be a little tricky because we are seeing everything from back to front. If we don't predetermine to go for posterior plating, I would simply put the patient on supine position, but bring the leg to the edge of the bed. And to allow internal rotation at the level of the ankle, I'll put a little bump under the knee to facilitate internal rotation of the leg. It will also give internal rotation at the ankle level. And there is no problem in doing it with posterior plating or lateral plating, because you can see everything from below. We have to really raise the bed above the level of height so that we can screw it from below up.
Yes, thank you.
Ravi Shankar, do you want to add anything? Dr. Ravi Shankar, are you there?
Ravi Shankar is not
okay.
there.
No, sir. Dr. Someshwar, sir, anything to add?
Sir, one more, sir. There are some fractures which are stable in weight bearing, but not in lateral and gravity stress tests. So how will you manage that? Whether to just go with weight bearing and or boot, or just fix it?
Yeah, that's a good question. Here, the point of stress comes into play. The weight-bearing X-rays or weight-bearing is not considered as an optimal stress to determine the instability. So that concept of checking weight-bearing has gone now. Regardless, you have to check the instability through an external rotation stress test only, which can be done in an outpatient setting with minimal discomfort to the patient. You can also give a little bit of local anesthesia around the ankle area when doing so. So it's the real external rotation stress test that gives an adequate amount to check for instability, but not the weight bearing area. If you think that weight bearing is stable, but external rotation stress reveals medial instability, then you have to believe in the second, not the first test. Weight bearing can be just because.
Srinivas, your internet is not proper.
Can't hear you properly, sir.
Sir, any other, all other panelists, anything to add, sir?
Can you hear me better, sir?
Yes, sir.
Yeah. That's nice, Srinivas, continue.
I was trying to say that the weight bearing is not a real stress to the ankle joint. The patient relying on weight bearing means we are really relying on the patient to weight bear. It's quite understandable that because of the pain, the weight bear just for 5 kilos or 10 kilos of their whole body weight. Of course, we don't expect them to fully weight bear, and it is something subjective to the patient, whereas external rotation stress test is something in your hands, which you can do it with accuracy. So studies have concluded external rotation stress test over weight bearing stress. So when you suspect instability on the medial side, in the outpatient setting itself under live flow, if that is available, then with the good counseling, and if necessary with some local anesthesia, you can do external rotation stress test in the way that we just discussed. And if that shows medial opening, that is a corroborative sign of medial instability, and that patient should be going for theater. Not to open on the medial side first, but to open the lateral side, stabilize the lateral column, check for syndesmosis, and then repeat the intraoperative external rotation stress test. If that reveals a stable tibiotalar articulation on the medial side, then you don't have to explore it. But if that still reveals a residual instability, either in terms of medial opening of tibiotalar joint or medial clear space widening, then we are duty-minded to explore medially and repair the ligaments.
Sir, anything regarding the direction of the syndesmotic screw? Any particular angle?
Should be in the
Yeah, obviously it has to be from the equator.
posterior.
From the equator of the fibula to the equator of the tibia. So it should be ideally in this direction only.
Yeah.
Nothing less, nothing more. I don't know where that image has gone. Let me put that. Yeah, here you go. So it's better to internal rotate the leg until the fibula on the tibia are exactly parallel to the ground, and then direct the screw parallel to the ground. Then resting the leg in natural external rotation and then trying to struggle colliding with the side of the bed and trying to estimate whether it is 10 degree of external rotation or 20 degree of external rotation. So my take on will be, I'll internal rotate the leg and then take a lateral view. I'll ensure what I said, that talar-dome lateral view. I ensure that the fibula and tibia are in the straight line, and I fire the screw as if we do for perfect circle techniques for interlocking. I initially put a K-wire and then take multiple images to ensure that it is in the right trajectory. There are some advanced centers in the world where they can do the intraoperative CT scan, what is called the O-arm. Just like C-arm, you have an O-arm. So that gives a perfect picture like this. You can see the trajectory of the K-wire. Sometimes they put 3 or 4 K-wires and they select the best K-wire that has the right trajectory and then the furthest. I think it will take some more time for that to come to our use.
There is a concept like a 3D X-ray.
3D X-ray, okay.
Yeah, anything like 3D CM.
Yeah, yeah, there you go.
Are they using in America, sir?
No, I have seen O-arm, but not in foot and ankle service.
Okay.
They use it for pedicle screws and sometimes for complicated spinopelvic fixation. But it was good to see an O-arm, like a C-arm.
So anything to add by the other panelists, sir? If anything is not, if nothing is there from other panelists, shall we conclude? Naresh, are you there?
Yes, sir. Yes, sir.
Yeah, please.
So there no more discussion. I think this is a wonderful session. Thank you all the panelists for sparing your valuable Sunday evening with us. And it's a great learning experience. Special thanks to Dr. Srinivaslu from USA for taking time to spend time with us. And also our President Subramania Garu for initiating the concept and bringing him to the podium. And Jahangir Basha from Kadapa. And special thanks to Raghunandan sir from Karnool and Chitra Garu from Karnool and Atmaram Garu from Anantapur and Ravi Shankar from Tirupati has joined and Someshwar Reddy Garu. Our executive committee members Ganesh Kumar Reddy, Leela Prasad for taking time and participating in the discussions. Sudhakar just also was joined and left it. So thank you all. It's a wonderful learning experience and nice interactive discussions with the case-based learning. Subramania sir, you can proceed and then finally from the KOSA.
Right. Thank you. Thanks a lot, Dr. Srinivaslu, on all the panelists. On behalf of OSSAP, I congratulate Dr. Srinivaslu to going up to, he should go up unlike anything. And it's a big applause to the Dr. Srinivaslu.
Thank you, sir. Thank you, everyone. Thanks
and
a lot.
I thank all the panelists, Dr. Achitrao, Dr. Raghunandan from Karnool, Dr. Atmaram, Dr. Someshwar Reddy, Dr. Ravi Shankar, and all the EC members who have joined on behalf of KOSA and OSSAP. I thank all of them. Jahangir, you can just add a few words.
Sir, as of I know, sir is an excellent person, especially in academics. So I wish him all the best. And I wish him to regularly come in touch with KOSA and OSSAP and help us in gaining the knowledge, sir, and latest updates also. Thank you very much, sir. Thank you for this great knowledge feast.
Okay.
I want to take this opportunity to compliment Dr. Srinivasulu. His approach, his methodology is very meticulous, step by step. There is no hurry in any decision making. Well, I learned that, you should look beyond the x-rays. You should look at the x-rays carefully, think about the fracture, and then, jump into the OT. And he gives equal weightage to the like hardware and the software, that is the bones and the ligaments. So congratulations, sir. And it was a very nice talk, and it very happy to interact with you. Thank you, sir. Thank you.
Thank you.
Hi, Srinivas.
Yes, sir.
Yes, it was nice to hear from you. We could learn a lot, actually. So before putting a knife, try to read well and try to have a knowledge about what you're doing in the OT and then plan your surgery and all that. I always tell my postgraduates, just by getting training in surgery doesn't mean that every case you operate. How best you can avoid surgery in the patient is your first
Thanks.
The motto, then only you can put your knife on, you have a license to put your knife on, doesn't mean that every patient you operate. And secondly, I think Dr. Srinivaslu is not meticulous Srinivaslu, he is meticulous Srinivaslu.
Yeah.
That's what
That's true.
He has been that attitude since beginning. The moment
sure.
I spoke to him long back from Kadapa, he used to talk to me regarding certain things. I observed that he's a very sincere man, and whenever I meet him in AO conferences and conferences, otherwise in Hyderabad or something, he used to be very knowledgeable person who has got a good grip on basics and very happy going boy with maintaining relation with all the seniors and juniors together. I wish him all the best in his future career, and I wish, as Jahangir said, he would continue to enlighten us with his concepts, basic as well as advanced, in all our fields during our meetings to come in the future. Thank you so much, Dr. Srinivas, and thank you, OSSAP, sir.
Sir, Dr.
Thank you, sir.
Somesh Reddy,
Thank you
sir.
so much.
Ravi Shankar, are you there?
Yes, sir, I'm there, sir.
Okay.
Internet problem.
Okay, sir. Ravi Shankar, you can just do it.
Thank you so much, Dr. Srinivaslu. You made our day. It was a very good learning experience. Both you, as Raghunandan sir said, you should be called meticulous Srinivaslu. Thank you very much. Keep enlightening.
Thank you. Thank you.
Sir's initial also M, sir.
Thank you, sir.
Sir, we'll call
Sir, we'll call
Thank
it.
you.
We'll go offline. If you want to stay back, you can just stay.